Thanks, Philip. Thanks a lot for the invitation, and thanks so much to all of you for turning up. It's a great turnout, and I know that it's lunchtime and it's raining outside, so being in the room is even more difficult. So Philip got in touch with me back in the summer to attend the conference. And luckily for me, I was lying on a beach in Spain when you were having the conference. So we kept going and we managed to schedule it for today. So I'm excited to be here. As Philip said, I'm professor of computational medicine. So what does that mean? I trained as a computer scientist around the turn of the century, and I've been working on applications of computer science to biomedical research, since then, and more recently, AI. Right? I for those of you who are old enough in the room, I remember the days before deep learning, all those things. So we've done other things apart from machine learning, to support advancement in biomedical research. And today, what I like to give you is my computer vision perspective on what is the potential for AI in health. And that is because my team at the University of Edinburgh mostly works on applications of computer vision to medical data. So let me start. I'm not sure if this is. Do you think we can? Oh, yeah. Okay, so let me start by showing you this quote. So this quote, maybe you can move the little window a bit. This is a quote by Professor Geoff Hinton, received the Turing Award in 2018 and received a Nobel Prize 2 weeks ago. And I'm starting to think whether I should slag off a Nobel Laureate in public. So I might change this purpose. But anyway, for the sake of argument. So Professor Hinton, a godfather of deep learning, said 8 or 9 years ago that it's quite obvious that we should stop training radiologists. Radiologists are the coyote already over the edge of the cliff who hasn't yet looked down. So this is quite a bold statement, right? And what Professor Hinton here was hinting at is that computer vision was going to replace the whole field of radiology. So now, and if you were to look at the popular media, an article in The Guardian saying that a simple eye examination could predict heart attack risk through some AI model running on the retinal image, or even in more specialized media, like specialized media covering Alzheimer's research, these bold statements of researchers developing first of its kind artificial intelligence model that could detect Alzheimer's through retinal photographs. And here I'm focusing a lot on retinal imaging because that is some of my research, but you find these kind of statements across lots of uses of AI for medical imaging, radiology, and so on. Now, if you look at the data, you will see that the number of jobs postings in the American Radiology Association job board has only been growing since Professor Hinton made this prediction. So it doesn't seem that it has quite materialized what he predicted. And I think what I'm going to argue over the next few minutes of my talk is that we have put a lot of focus on the development of the deep learning models that run on those images, but we have somewhat neglected some other aspects where we really think are needed in order to make these AI tools really a day-to-day support tool for clinicians, for radiologists. So I'm going to talk about this life cycle of development of a computer vision system to support healthcare. So we all know that models are as good as the data they are trained on. We know how to develop models. But then those models, once we've written a paper and we publish it on some fancy journal, if we really want them to one day change clinical practice, they will have to be implemented in the real world. And we'll have to evaluate how effective they are. And although computer vision and deep learning sit at the very core of this pipeline, all these additional disciplines are equally important. And what I will argue in my talk is that we've put a lot of emphasis on the model development. We got the headlines on The Guardian just by doing this, but we haven't yet done too much of implementation or indeed evaluation to demonstrate that those claims that we can detect heart attack, using a retinal scan, indeed materialize in fewer people dying of heart attacks or on savings on the healthcare system. And I think we too often neglect that the models are as good as the data they are trained on, and we suffer from issues of bias in a lot of the data sets that we use. And data in medical imaging has some issues around privacy. It's very difficult to create the image net of, brain CT or chest CT or brain MRI, because there are concerns of privacy, because there's highly sensitive data. How we make data interoperable, so it's not enough to have access to the retinal images that I will be talking about, but I also need to have access to the clinical outcomes, 15 years down the line, and so on. And in the rest of my talk, I will present work in 3 different projects that I've been developing in my group, but in collaboration with quite a few colleagues at the University of Edinburgh, where we are beginning to address some of these issues for very specific applications. So I'm not claiming that I have come up with any, general solution to this problem. All right, so let's start talking. My Scottish friends force me to pronounce this school, but I know that, depending where you are in the UK, this will have one pronunciation or another. So you've heard this before. The retina is a window to investigate microvascular health throughout the whole body. So this is a fundus photography. This is the retinal tissue at the back of your eye. You can see through the pupil. And there are some landmarks. That is the optic disc, that is the macula, that dark patch there, which is where central vision is formed. And obviously, optometrists and ophthalmologists use these images to track the health of your eye. But what we have now is about 2 decades worth of scientific literature demonstrating that there are associations between changes in the vascularization pattern of the eye and diseases associated with problems of vascularization of the brain, kidneys, heart, and so on. So I'm not going to show you data on this. You're going to have to take my word for it that this is quite widely, investigated. And this gives us a very interesting opportunity, which is that unlike an MRI scanner, which is really expensive, and we only have a few, spread in some key hospitals here and there, it is really, really cheap, or should I say, inexpensive, accessible, and scalable to image eyes. Because every optometry practice, every Specsavers, every Boots opticians, every independent optician out there, and there are tons of them in any sort of city, high street, etc., have one of these cameras. And furthermore, this is quite well-established optical technology, and we are starting to see the developments of handheld cameras that can be deployed in low resource settings, generally scalably. So this really opens an opportunity to monitor the entire population at risk in the high street. So that's the dream. I hope this retires me in a few decades from now, but we are not quite there yet. So to train models that are really generalizable and scalable and work across a broad population, we need data that is representative of the whole population. And what we set out to do 4 years ago was we started this project called SCOON, which aims to collect 10 million NHS-funded retinal images, link them to health records, and I will tell you what that means in a second, and deliver AI technology for eye and brain disease risk prediction. And this is predicated on the fact that there are about 900 optometry practices in Scotland all throughout the territory, and they collect about 1 million images a year for those over 60. So the NHS pays 1 eye scan a year for everyone 60, plus every 2 years for those of us which are below that age for now. And there are 10 years worth of this NHS-funded data. And in the contract for the optometry practices, they are mandated to keep that data for 10 years. So if we don't start collecting it, they're going to start throwing away the hard drives. So that is what we set out to do. And we've worked in 2 phases, which will conclude next year. And basically what we have now done is we set out the data governance, so the legal basis to go around these optometry practices, collecting the images, the IT infrastructure to store them. This is unconsented data, so it has to be stored in a particular way with certain guarantees, supported by Public Health Scotland. We had to engage the community because it is the individual owner of each optometry practices that has to sign a data sharing agreement. And basically, we engaged Scottish government, got their support, and this has been going on for 4 years now. And what we have now is about 700,000 images ready to use in the National Safe Haven of Public Health Scotland. And this is arguably the largest retinal image repository in the world. But what makes it even more unique is that we can take all those retinal images and link them to hospital records, link them to prescription data, link them to death records. That is thanks to the facilities that Public Health Scotland provide for data linkage, etc., etc. So there is no parallel to this. And recently we got a further investment to work on a project related to brain health outcomes. So let me tell you a bit about how those images look like. So this is about half the cohort. At some point we decided to write a paper, so this is how many images we had when we wrote the paper. So that is the spread of number of images over time. So going back all the way to 2006, 2007, that is the time where those images were taken, about 20,000 a year. Little drop in 2020. What did happen in 2020? Well, people stopped going to the optometrist, and this will likely manifest in increase in certain incidents of conditions. So how does this data look like? And surprisingly, women are more concerned with their health than men, so they go more often to have their eyes checked. And the median age for those in this data set is about 70 years. So this makes it quite a relevant data set to start looking at cognitive decline, which is one of the objectives. This is the socioeconomic distribution in blue of the Scottish population by sort of deciles of the Scottish Deprivation Index, and in purple, the socioeconomic distribution of our data. So luckily, we have an overrepresentation of those less well-off in society. So this is very important for biases. And I know that this is a lot of numbers here, but basically these are for the different conditions of interest: eye conditions, neurodegenerative conditions, systemic conditions, the number of individuals that we have been able to identify by cross-linkage with the health records, how many images we have from them, how many are before the diagnosis, how many are after the diagnosis. So with this, you're going to start asking the question, for someone that was diagnosed with Alzheimer's disease, say, was there any sign in those images 10 years prior that would have been indicative to this? 5 years, 3 years, 2 years? And probably all of you can already start to picture the kind of machine learning work that you can do based on this data. And you need a big infrastructure to be able to deliver this kind of research, right? So this is not something that I do on my laptop. So we take advantage of the National Safe Haven, run by Public Health Scotland, which is part of NHS Scotland. And basically what we do is, after engaging optometrists and data sharing agreements, etc., those images are ingested into the National Safe Haven. And in there, the personal identifiers that we bring with the images are replaced with Chi number, which is the unique number that all of us have in the healthcare system in Scotland. And through that Chi number, this linkage step can bring a range of additional data sets. So hospital records that I talked about before, but for instance, there is a sister project of schools called Scottish Medical Imaging Project, which is making a copy of the PAC server of the NHS that contains all the radiology exams, MRI, CT, X-ray, and so on. And those are also uniquely identifiable by Chi. So thanks to the infrastructure, now we can start crossing all these data sets with prescription data, with death records. So, your imagination can fly here. Obviously, a lot of forms to fill, to get access, permissions, ethics, and such and such. It's not something that one can do in one afternoon, but it really Scotland at the moment is really at the forefront of this type of research, and we should sort of keep pressing. And obviously, on the back of that rich set of data, you can start developing, your usual sort of supervised learning based on the labels that you get from the health records and your images, and or for instance, you can start looking at which you can do feature engineering on the retinal images and feature engineering on the brain scans. Maybe you're interested in measuring, shrinkage of brain volume or a small vessel disease, water matter densities. Those are features on the MRI scans. And you're going to start to not only develop this sort of black box supervised NL that will tell you the likelihood of a disease, but you can also start to relate with in the retinal image associates with the finding in the brain scan and start to dig deeper about what is underlying those associations. Okay, so that was related to the first topic of data, the need for rich data set, for sophisticated data sets. So what I will tell you next is a piece of work that I've been doing with colleagues funded by Wellcome League on how to take one of these models that is already trained and published, and we try to implement it in routine care. So as I said, there was a project funded by Wellcome League, which is related to Wellcome Trust. Not exactly sure what the structure is. And here what I want you to know is that the objective of this project is not, let's come up with some machine learning algorithm that can predict myocardial infarction in an area under the curve of your favorite number, right? So when you get serious about implementing these models, what you have to ask yourself is, what improvement can my model make on the standard clinical pathway? So clinicians are working in some particular way. Where can we bring tools that either save them time, allow them to see twice as many people in the time they have, which is basically the same, or they can see the same amount of people at a fraction of the cost, etc., etc., etc. So here, what we wanted to do was implement a machine learning algorithm for the prediction of acute coronary syndrome, heart attacks, that reduces 30-day reattendance in hospital. So you have chest pain, you should go to A&E. I'm not here telling you not to go, but you go to A&E, the specialist there will see you, and some people will be immediately discharged, some people will be kept in observation, some people will be rushed into the operating theater. And what we are trying to achieve here is that the people that are discharged, they are discharged with a degree of reassurance that makes them not turn up in 2 days again, because the symptoms manifest again. And there were 3 streams of work here, to do with the modeling, of course, but how we connect the models to the data streams in the NHS, and also how we co-design the solutions with the clinicians so that they want to use them. Testing, implementation. So this is still ongoing, but I will give you a few highlights. So the model was developed already and published. So it's this model that we published in March last year, a machine learning for diagnosis of myocardial infarction using cardiac troponin concentration. So we demonstrated that by integrating this troponin assay into standard risk prediction models, and here we developed basically a gradient boosting algorithm that combined all those features together, nothing that you've never heard before. We were able to get very accurate predictions of myocardial infarction, both yes and no. And this was picked up by Nature Medicine, and there was some very nice editorial that was written about it. And obviously you can just publish the paper and move on, right? But what we wanted to do here is really see what it would take to implement this in the real. And here, what I want to illustrate with this rather busy slide is that this model takes a bunch of features, both from standard clinical records, from lab assays, information that the clinician inputs, and it will return a score. And I'm not even going to explain how that score is calculated. But thanks to this score, what we have is very high sensitivity, very high negative predictive value for discharging people with a high likelihood that they are not having a heart attack. That chest pain is of another origin. And we want to be able to do this with confidence, discharging this person to be followed up by the GP rather than this person coming back to the hospital in 2 days. On the other side of the spectrum, for a high enough score, you've got very good specificity. Finding those that have a heart attack, and indeed these people will be rushed to the cath lab, to have their procedure done. And there is this gray area of people that will be kept in observation. Maybe the assay will be repeated. We can run the model again, 6 hours from now, see whether they fall in any of the beams. And here, really what we are trying to do is those that get discharged, that we can discharge, that the clinician feels confident to discharge them so that they don't have to be kept unnecessarily under observation. So those that need observation will be kept under observation. Those that need to be rushed to the cath lab, they will be. But those that we can discharge safely, we will support the clinicians doing that. And with this diagram, I'm clearly just trying to bamboozle you, because from all the stuff that I have showed a moment ago, that is the AI model there, this little box here. But here what we have is a user, a clinical user, a clinician that is interacting with TRAC, which is basically the electronic health record system used in NHS Lothian. And this is basically what the clinician will be using to record the findings, request additional investigations, etc., etc. And basically what had to be designed here is a parallel clinical web portal, because it's absolutely impossible to sort of inject code into one of these systems. This would take probably 2 decades of talking to the developers and having everything validated and reassured and so on. That can draw data from this system, because a lot of the features that go into the model are in this system, can draw data from that system, can collect additional data that is required from the model, and at some point can, call the previous ML model that I described to you, and then present some output here. And you should have seen, the first few weeks, there was at some point last year, we spent 3 or 4 weeks, just to get these messages to cut across all the firewalls that the NHS rightly have installed, right? So we were like just triggering the message. Is it going to go through? Is it going to go through? Is it going to go through? Yeah. After weeks of various changes in setups and talking to networks people and so on. So this is far from trivial to put it into practice. And then there is an ongoing study design. Again, a lot of text in this slide. Randomized, people get randomized either to standard care or AI-guided decision support, and we try to see what changes there to a primary outcome. But what I want to draw your attention to is to this hypothesis of the study design. So the hypothesis here is not that we will be able to achieve, point whatever you like in terms of area under the curve or sensitivity, specificity. What we want to ascertain here is that AI-guided clinical decision support will reduce the duration of the stay and subsequent hospital attendance in patients presenting in A&E with possible myocardial infarction compared to standard care, because this was the need that the clinicians identified, that we've got way too many people that are in a bit of a gray area. We think that they are probably okay, but we don't have any way of reassuring ourselves that they can be discharged. And these were the savings into the healthcare system, it's very unlikely that you will trigger savings by. They are very good at finding people with a heart attack already. The assays are very good. So it's very unlikely that you will be able to improve the positive predictive value, the detection rate. And then to finish, I like to tell you a bit about a third project, which is concerned with once those systems have been installed, well, once they've been running for a while, how we can evaluate them to demonstrate that they are cost saving, they improve outcomes, and so on. So this is the impact study, which finished 3 months ago, and we are currently writing up for submission. And here, the objective was to run a real-world mixed methods evaluation of the impact on and outcomes from radiology decision-making using AI software for pulmonary nodule management. So what we have here is a company that back then was called Aidence, but now has been bought out by an American company called Deep Health. And what they've been doing over the years is developing not only the models, but the integration with the healthcare systems, with the PAC servers, with the radiology consoles, and so on, for a computer vision system that analyzes chastity and finds lung nodules. So lung nodules are some presentation on the chastity. You know, it would look like some sort of blob in the chastity. Some of us will carry these masses in our lungs for our life, and nothing will happen. But some of those will develop into malignant lesions, and they can become cancer if left unchecked. And this evaluation, yeah, this is important. Yeah. So this evaluation was, again, not predicated on the case of someone who has suspected lung cancer arriving for a CT. That case is quite well handled because you have specialist radiologists, people are very trained to find the lesions. But here, what we're trying to do is for those of us that get a chest CT done for any other reason that has nothing to do with investigation of lung cancer, the radiologist in charge has to check for incidental findings of lung nodules. Even if they are looking for something else, they will have to go through the slices of the lungs and try to identify incidental findings. And what will happen often is that you might not have a specialist lung, say, radiologist looking at those scans. And that is the point where we are trying to, enter here the clinical pathway. Supporting radiologists that might not be a specialist in detection and quantification and management of lung nodules, and provide an AI system that makes them perform at the same level as their specialist colleagues. And this was quite a complex evaluation. So there is a clinical impact study, which is what I will describe today. But on top of that, we did a bit of qualitative work, investigating user perceptions, patient and public views. And we also went as far as doing the health economics of whether the changes in management recommendations that I'm going to show you in a second, whether they are actually cost-saving or cost-inducing for the NHS. So this ran in 6 hospitals throughout the UK. We managed to collect data from 4 of them. And here, the methodology is as follows. So there is something called the British Thoracic Society Guidelines, which basically is a common framework on how radiologists should interpret chest CTs, right? And I don't have time or knowledge to walk you through all these different, all these different pathways, even more because this box takes you to another figure in the paper, which is algorithm 2 and some other figures, another figure. But through this decision tree, you will see that at times it queries whether a nodule is less than 8 millimeters in diameter or less than 300 millimeter cube in volume, or it queries whether it's not in this diagram, it's in algorithm 2. It queries whether it has doubled in size since the last visit, and so on. So this is where the AI system comes in. So this computer vision system, what does is does nodule detection, segments nodules, quantifies their volume, gives also measurements of texture, which is to do with the composition of the tissue, and so on. And the way that the trial or the clinical study was set up, a patient will undergo routine chest CT for some other indication that is nothing to do with lung nodules. The radiologist will read the scan. Read is the jargon that they use for analyze, investigate, report, without the AI system. And after that, the radiologist will do it using VLM, using their computer vision system. And what we will record is the decision without and with the AI system support. And then separately, there is another arm where these scans are reread by a specialist, a cardiothoracic radiologist that will sort of provide the ground. And the difference between this and this is that they will be presented with additional information of segmentation, where the nodules are, volume, and so on, that they can use when they go through this decision tree, rather than visual observation or a tool that the PAC service has, where they can click here and here and get an estimate of distance and so on. And I'm sure that you see lots of issues with this design, right? And I'm sure there are lots of other designs that we could do. This is not randomized, this is not double blind, etc., etc. And this is something that I will only touch in passing, which is, it is still an area of very active development, how one sets up evaluation of AI systems in healthcare, because we are used to run trials for drugs, and we know how to do randomized control trials. But it's not. I cannot imagine a way of doing this double blind where the radiologist doesn't know that it's using an AI tool, right? So it would have to be something very, very sophisticated. And the literature, there was a recent review, showing different types of designs for these kind of clinical trials. And what we implemented here in the literature is known as a case-by-case sequential paired study for comparing diagnostic performance. And this has some advantages and obviously some disadvantages. But one advantage that I like to highlight is that for this study, patient consent is not needed. And this might seem surprising. And then the reason is that the subjects of the study here are the radiologists themselves. So we are studying radiologists that can consent to take part in the study, because we are not changing the clinical pathway for the patient at all. And although this might seem trivial in terms of setting up the study and getting all the approvals and so on, this really makes a difference. It would be a deal breaker to have to collect consent from every patient. All right, so some preliminary results, hot off the press. So 1,400 exams were reported by 25 different reporters in 4 sites. 1,264 were de novo cases. So de novo here means the patient has no previous history of lung nodules. This is a scan that was not required for investigation of potential lung cancer. And these are tables with, the number of cases, reasonable split between female and male, mostly white participants. Then this is the radiologists themselves, 25 radiologists across 4 sites with different levels of expertise and various degrees of specialty. And from those 1,264 cases, there were 237 cases where an incidental pulmonary nodule was found. So about 19% of those CTs that were prescribed for something else indeed had a lung nodule in them. So this is quite common. And what we were able to quantify is that the AI system led to 27 changes in management recommendations. So 11% of those were affected by the AI system. And you can look at this from 2 angles, right? You could say, well, we are not really making such a huge difference. Or you could say the radiologists are doing a really good job already. And I think I prefer the second interpretation. Because what is demonstrated is that the radiologists are doing a really fantastic job. And it is a very few corner cases where you can help, which is those 11 cases. And I will break them down for you a bit more. So there is some initial analysis that we have done. So these are some confusion matrices. So basically here what we have is on the left, cases where using the AI led to a decision that is in line with the ground truth done by the specialist radiology. And I have identified 2 different cases. So we had 21 cases from 200 and something that without the AI tool would have been discharged. And with the AI tool, they were kept in the clinical pathway, and indeed 20 of them were referred for a follow-up 3 months from now or from then. And maybe some of those will be discharged in 3 months, but perhaps some of those, will have been a case of lung cancer that was detected at an earlier stage, that this person had been discharged and only come back to the hospital with some severe pain, 2 or 3 years from now. So this is indeed a reduction in the cases of incorrectly discharged. So this is superior performance. Then we've got these 4 cases here that without the AI system, they were either sent to 3-month follow-up or to workout. So this is sort of the most critical case. And thanks to the AI system, we correctly discharged them. And these are prevention of overtreatment. So overtreatment in this case is savings for the healthcare system, but it's also less radiation for that person when they go for another check a few months from now. But then the flip side of the story is that in this confusion matrix here we have cases where the radiologist without the AI agreed with the ground truth, but the AI confused the radiologist or led it to change their decision compared to what it was the correct decision. And this top row here is induction of overtreatment. So these people should have been correctly discharged, and with the AI system, they were put on this schedule of follow-up. So this is additional cost for the healthcare system, additional radiation, investigation, worry for the patient. And then we've got this case here where without the AI, this person was referred to immediate investigation by a specialist, which was in agreement with what the ground truth told us. And with the AI system, this person was, or would have been, should have said, would have been incorrectly discharged. And we think a bit on what might have happened here. And this was a lung nodule that was located in a very unusual location. And it seems as the radiologist spotted it initially, but because later on it didn't see the AI tool picking up the nodule in that location, it kind of second guessed himself or herself because it wasn't the kind of place where you would expect to see it. And I think this gives you the whole range of outcomes that an AI system can have on the detection of lung nodules. So I'm gonna conclude. So hopefully I have convinced you that there's a very strong case for the use of computer vision algorithms to assist clinicians. So no coyote over the edge of the field. You know, we want to assist clinicians, we want to assist radiologists, we wanna really target the weak spots in the existing clinical pathways where we can do better, where we can save costs. I think there's a much more adult and much more serious take on what AI can do for medical image interpretation. They just say, you know, we're going to find this in everyone, so on. We can replace radiologists. This audience doesn't need me convincing you that the latest development in deep learning have demonstrated that this is indeed feasible in many common tasks. But what I have argued today is the success in this space will very much depend on large multidisciplinary teams and sophisticated approaches that are able to bridge this whole path between data collection, model development, implementation, evaluation, and how the results of that evaluation tick all these previous boxes, not only the data, but also the model development, implementation, and so on. And I think this is where we are now, and I think this is where sort of there are plenty of opportunities for making contributions in the field. So I forgot to put an acknowledgement slide. I apologize to my collaborators for that. I'll close the talk now and I'll welcome your questions. Thank you.